Today we will be discussing about bleeding tonsil. Okay, so has anyone of you uh, faced a case in which you have had a patient who was operated for tonsillectomy and was presented in emergency as bleeding tonsil case? Have you any one of you who has the experience to manage that case practically? Yes, please. Any response? No response.
Yes, yes, we have. I mean, there are a couple of people who have said yes, they have.
I'm sorry, Dr. Faisal. Welcome and thanks a lot to join us. Just a second.
Thank you so much.
Okay. So what are the concerns in such baby which was operated before, maybe 6 hours or 8 hours before, and now that patient is presented with the history of bleeding, and what will be the challenges in that patient? Anyone please? Sumaira, can you speak out please? Because you are the exam candidate among us, and if you can take the lead. Sumaira, are you audible? So actually, usually this patient, you have certain challenges which you have to face. Like one of them will be that baby may be in shock. Okay, according to the level of bleeding, it is difficult to assess the bleeding. Okay, because the bleeding is not visible, and baby may be aspirating it, and now it's difficult to assess that how much bleeding has been done. Okay, and the only thing you will be according to the level of dehydration. Okay, and like the signs will be some tachycardia, or like according to the age, the parameters will be blood pressure maybe decrease, but as blood pressure is not as good criteria for assessment of shock in the younger age group as compared to in adults. Okay, so there may be some like a patient baby may be anxious. Okay, and crying. Okay, so now your challenges will be not only to assess the situation, and now there may be ongoing bleeding, or then you will have to make a plan to how to proceed. Okay, so this baby
aspiration risk is there.
I'm sorry.
Aspiration risk.
Yes, aspiration, because this will be all the blood which is baby is inhaling is in the stomach. So like there will be risk of aspiration. Okay, and because this will be a second anesthesia, so there may be some residual effect of anesthesia, as well as some because babies have narrow airways, so there may be some sort of airway edema. Okay, so you might need to have you might need to see the anesthesia chart, and now when they are reoperating, so the endotracheal size tube may be slightly of less diameter. Okay, so
patient anxiety is there, emergency is there.
Yes, and so like these, so you have to discuss with the surgeon, and then you will be taking the patient. At the same time, now you have to arrange the blood and blood products as required. Okay. And so how will you intubate the patient? What will be the challenge which you can have during the intubation? You have to do rapid
Sir,
sequence.
in this
Low blood
patient, we
pressure?
go with the rapid sequence induction,
Okay.
and we may face a difficult intubation
Okay.
because we are going for second intubation due to upper airway edema, and
Mhm.
there will be a risk of aspiration due to bleeding.
So rapid sequence
And
induction, will you do rapid sequence induction?
sir, we can go with a modified rapid sequence induction, like we can give titrated doses of induction agent because
Will you
patient may
choose
have.
will you choose propofol versus you will go for ketamine with midazolam?
Sir, ketamine and midazolam.
It will be depending on the situation according to the level of bleeding. Okay. So actually
And
this will
according
be
to hemodynamics of the patient.
yes. What else other than this one? What else you need to know? Urine output will be also good. It will be a good criteria to know whether how much dehydration or how much bleeding has occurred. Of course, exactly it is difficult to assess. Okay. Now some questions. After intubation or before intubation, would you like to pass NG tube or no?
After intubation,
Okay. So what will be the advantage?
you can empty the stomach, and post-operative, there will be no nausea and vomiting and no regurg of the stomach contents.
And there may be need of, because of if stomach is full, so you may need problem related to even in the ventilation. Okay. So
Of course.
you might need to deflate the stomach. Okay. So this will be one thing. What else? Anything else would you like to do? We will go to the text shortly, but I just wanted to have now, for example, when like any other ENT case, the same repetition that it is a shared airway. Okay. You need to put a throat pack. Okay. And what else? Would you like to ask about the technique? Is any effect is there any association with the certain technique which the ENT surgeon has taken on the bleeding? Is there any difference? Have you heard of hot technique or cold technique? Okay. Is there any association with it? Do you know about Sumera? Do you know about this hot technique or cold technique?
Sir, no, but I think that there is one with the some people do with cautery, and some do with that other. They have some effect on, I guess, on airway edema. But I didn't hear about hot and cold technique.
Actually, this is like if they are using too much cautery. So this is one of the factor of severe pain, and this patient have more chances of bleeding. Okay. But in reality, actually, sometimes they just put a suture and just crush the blood supply. This is also being done but actually this is a combination. Now there is no pure hot technique or cold technique, but usually if they are using too much cautery, this is one of the factor for even pain, and this patient has more incidence of bleeding, if I'm not wrong. Okay. So these are certain things which you will be looking at. Again, that it is an emergency case. It is difficult to evaluate the patient. You will have a difficult intubation. You have risk of aspiration. You have a baby which always has a challenging airway, challenging hemodynamic, altered physiological, pharmacological, and anatomical considerations. You have to maintain the blood OR temperature. You have to prepare the medications in diluted manner. you have to use the titrated amount, especially when your patient maybe in shock. Okay, so you are using different size of blade. You need suction with you. You need to have proper size endotracheal tubes. There is always a debate between using a cuffed versus uncuffed endotracheal tube in pediatric population. Okay, but in this situation there will be a little less difference, because anyways you are packing it, so some of the difference will be lost in this scenario. Okay, because in any other pediatric patient, when you are not having a throat pack, you need to seal the airway. So if you are not using the cuff endotracheal tube, you might have some problems. Okay, so these are the general scenarios. So in this scenario, why this is a common scenario to assess, because in this one scenario they will be asking you about the physiological, pharmacological, anatomical changes in a pediatric patient. They will be considering your concepts about the ENT surgery. You are they are judging you about how to assess the level of bleeding in pediatric patient, and or a sort of patient in which you are not visualizing the bleeding. If the bleeding is coming out through a drain or anything, you can evaluate. There are so many other ways to evaluate, but in this scenario you will be short of like resources to assess it. Okay, then like in any ENT cases, there are chances of tube dislodgement, shared airway, problems related to bowel Davis mouth gag, whether you are using like a reinforced tube which will be resistant to like kinking. Okay, so there are so many things in like in slightly elder more older patients. They might sometime need to have this nasal endotracheal tube, but usually in a young age, like I think in the age group where there are chances of associated adenites as well, so usually they don't ask. But anyways, this is the sort of discussion which you need to have when you have a patient for adenotonsillectomy or tonsillectomy. But bleeding tonsil patient, you have all these things. Surgical maneuvers, they have to find the site of bleeding, and they might need to pack the area, and there are so many things which you will be related. So now we will have a look at the text. Sir, Dr. Faisal, it's a pleasure. It's an honor for me to have you on board. So if you can add some points before we just go to have a look on the article, Dr. Faisal, if you can have some
Uh,
few words.
Thank you very much, Richard. I was just going through my WhatsApp, and luckily the time was there. To manage, chalo, let's hear what's going on. Now, thank you very much for presenting this topic. Or it is an important one. Or आपके FCPS or even FRCS, mein, this is also a question which is quite frequently asked, and rightly said कि ये सारी चीजें आपकी
Faisal bhai,
test करता है.
sorry to interrupt you for a second. There are some people from across the border, and I think one of them is from Arab country. So try to.
I'm sorry.
Sorry to
I'm
interrupt.
sorry. I'll try. Sorry. No, thank you for letting me know that. So basically, this is an important topic, and it is a topic which is actually quite frequently asked in your final exams, both in fellowship exams and Royal College of Anaesthetists, as well as back in Pakistan, as well in your FCPS one. Rightly mentioned. I mean, when you talk about bleeding tonsils, I've written in the chat the points which are to be considered, i.e. the hemodynamically unstable patient. You've got residual effects of previous anesthetic. You may have a patient which was an easy intubation before, may not be an easy intubation now because of all of the soiling of the blood of the airway and things like that. And not only that, you also have to remember that there are parents who are very anxious that they've taken their child for an operation and now they've come back bleeding, or they are in the recovery and still the kid hasn't come out yet. And you've said that, oh, the operation will take half an hour, 45 minutes, and 3 hours down the line, the child is still in operating theater. So somebody has to sort of inform the parents or guardians that, yes, everything is going all right or whatever, and we are sorting things out. So they need to be counseled as well. So we tend to forget that point as well. Coming back to the intubation side of things, how are we going to intubate or how are we going to anesthetize this patient is always a thing that some people say rapid sequence induction, whether to use propofol, not to use propofol, whether to use ketamine, whether to use midazolam, whether to use an inhalational induction, and things like this. Is all to be honest is different. If you have to use IV induction with cricoid pressure, that is also correct. If you have to do inhalational induction, that is also correct. Whatever is safe is the way you have to do it, and whichever is safe in your hands. And you can argue on both sides. There's no right or wrong answer to that. And of course, rightly said that once you've done the procedure, of course, you have anesthetized the patient, you can always put a nasogastric tube in to aspirate, but sometimes it's very difficult to aspirate clots out from a nasogastric tube once they are in the stomach. So if you can decompress it, you can, but it's very, very difficult actually in practical experience. So basically, when extubation is more or less awake extubation. And resuscitation, of course, is also important before you embark onto this. But very nicely presented, and you have all covered all the points anyway. So thank you very much. That's all I have to say.
Thank you, sir. Thank you, sir. Just for the introduction for other people who don't know Dr. Faisal, he is son of one of our greatest legends from Pakistan, Brigadier Salim. He's son of Dr. Brigadier Salim. Of course, sir, you have your own identity, but of course, because we love you even more because of your relationship with our great teacher. Okay, sir. Thank you. So
that is very kind of you. Thank you.
Okay, so I think in this our discussion we have just tried to cover like as I mentioned, and sir also endorsed to few of the points. Like this is very, that's how we learn every day. Like I told about NG, and Dr. Faisal added that it is very difficult to aspirate if there are already clots. So you can just by like deflating, you can remove some of the volume, which can help, but you cannot remove the clots. So that's something important. And then challenging situation will be how to assess the level of bleeding, and like how to replace it. So you should have very good idea about how to assess the blood volume. And then you will be starting the blood transfusion. You can do an ABGs to see, or if you have non-invasive way to assess the hemoglobin. Otherwise you will do an ABGs after induction, and then later on you will replace with all the theories which we have, that how to assess the level of dehydration. That will also be a part, and now you have to replace the hemoglobin part as well. So you will assess the level of dehydration, and there are formulas, a number of formulas for it. You have to use usually isotonic fluids, and then blood accordingly. Okay, so any point anyone or one wants to ask any question, please? So actually this in our lately we have started this book, Clinical Anesthesia Viva book, and I'm just trying to cover different topics from it. Okay, so we had day before yesterday, and before that we covered preeclampsia and obstetric hemorrhage. So inshallah in coming days we will cover some of more topics. I think we have covered almost all, because this is a very common question being asked by a number of people in the exam. Okay, so I think any questions, please? Sumaira, are you clear? Any other exam candidate, anyone else want to ask anything?
Sir, which artery bleeds most often after tonsillectomy?
I'm sorry?
Sir, which artery bleeds after tonsillectomy?
Yes. This is a weak point for me. Just a second, let me see. Tonsillar, sir, Dr. Faisal, can you have any comment about it? Because you see, this is the blood supply of from external carotid.
I've just answered the question. Be honest, for exam, it would be fine. You have to look it up yourself. I don't remember, but to be honest, it doesn't make a difference whichever artery it is.
Yes.
Your job is to resuscitate the patient, and it's a surgeon's job to fix the bleeding. And yes, exam might ask, okay, the anatomy, explain the anatomy of the carotid artery and the external carotid artery. Be a branch of the external carotid, probably some tonsillar artery coming over there. But
Yes.
frankly speaking, I won't know which artery it is. But I doubt it. They will ask you this question: what is the tonsillar supply of the artery? Because it's not your job. Your job is to actually stop and resuscitate the patient. That's the
Yes.
main thing. And I guess the surgeon's job is to fix the artery and find out which artery it is.
Yes. So Sumera, you can see in the screen. I have just shown this article. That's why, I invite all of
Yes,
you.
right, sir.
I'm sorry. So this is
Okay, sir.
ascending pharyngeal artery, a superior pole, and this facial artery branches, dorsal lingual, mainly the branches from external carotid. Okay. So I think, and that's it. So thanks a lot, all of you. Just have a look, and that's again a message to the juniors. Please try to come out of books and try to read articles, because this will give you the
One
best.
question, sir.
Yes, please.
Most of the examiners are asked that there is a bleeding tonsil patient in the recovery area or in the ward,
Okay.
and the surgeon immediately want to push the patient from PACU or ward to OR.
Okay.
As an anesthetist, do you accept the patient immediately or hold the surgeon for some management?
Actually, to be honest, of course, in this scenario, if patient is bleeding, you cannot delay. Yes, you will be doing the resuscitation simultaneously, because if you you cannot delay. Okay, you have to arrange the things. You will call the blood bank, you will get the blood, and you will push the patient. You will take IV lines, and then you will proceed. As Dr. Faisal can also comment, sir. Please, if you have some other.
The thing is, depends. I mean, if the patient, just think about it. You've got a bleeding patient, and where can you manage this patient in the best possible way? If he is in the ward, you won't be able to manage it over there. Won't you like to keep him right in front of you and in the most safest place? I think in hospital, the operating theater, where
Yes.
we've got all the monitoring equipment, all the drugs, everything. You can get access to blood, O negative blood, or whatever, if you can't find any other blood. But at least you can resuscitate them in a better way where you are standing. Would you like to go in the ward and manage these patients, or would you like to leave this child to be resuscitated by the surgeons over there and then bring the patient? If it was my child, I would actually pick up this child, bring it to operating theater, resuscitate the child in theater, and once they are stable, straight away tell them, okay, go ahead and sort out the bleeding. That would be my opinion.
Yes, sir. I totally endorse too. I hope you got the answer, Dr. Maan. Okay.
Thank you very much.
So, anyways, thanks a lot, everybody. So this was it seemingly it's a very simple topic, but it is just like a jigsaw puzzle, and it's like a octopus, because so many topics are related to it. They can ask you about the level of dehydration in a pediatric patient, and rest of the thing which I have already discussed. Okay, so tomorrow we have a session for MCQs, and it will be 3 p.m. Pakistan time. Okay, so thanks a lot, everybody. A special thanks to Dr. Faisal. Thanks a lot, sir. Inshallah, we will meet again. Assalamu alaikum.
Thank you very much. Well done, all of you, and good luck with your exams.